This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 83 of the No Stroke Podcast. I'm Dave Dansereau. I'm here with my co-host Mike Garrow. And Mike, life is good again. The heat has broken. Went out for a run this morning. How is it over there where you are?
Yeah, it was about the same. Yeah, yesterday was a scorcher. So in this new apartment Meg and I are in, we just have I haven't really upgraded the AC equipment. We came from central air. Now we're back to using window units.
Okay.
And yeah, we need to get a couple more because my office has been without an AC.
Oh.
It's been brutal.
Oh boy.
But yeah, we're back in the cool.
All
so
right.
Nice 70 degrees today.
Well, I'm not branding for Life is Good, but I have to show you this shirt. This was my Father's Day gift, and how appropriate, right? First of all, it looks just like my dog. And everywhere, this is my family.
Every snack you make, every meal you bake, every bite you take, I'll be watching
I'll be watching you.
Good.
And
That's
it's so
cute.
true. The dog
cute.
is like stuck to my hip, and they got a laugh out of it. And so I figured I'd wear it, give it some mileage, give Sully another shout out.
There you go, Sully. There you go. What a guy.
So we've been keeping a cadence. We said, a couple of shows ago that, summer was going to be, maybe once a month, but we're busy doing stuff on our own. And you transition, you like you mentioned, you're in a new place. What else is new for you? You've been keeping busy?
Keeping busy. I was coaching. I moved, I think earlier this year, we were chatting maybe around the coaching gig I had when I was with the 8th graders, the young guys. In the spring, then I moved to a 16 and 18 U team. So they kept us busy. We were traveling all over New England, a few tournaments. But that's wrapped up. And yeah, now Meg and I are heads down into a small business venture. We're trying to get a mobile sauna and cold plunge business going.
Perfect.
So should be pretty cool.
I just followed your Instagram last night, and give the name, because I really think folks should follow what you're doing. This is a great venture.
Right? Yeah. Thank you. It's called Drip Sauna. So DRYYP. It's the Norwegian spelling for drip. And I mean, when you think about sauna culture, especially like traditional sauna, so not thinking, your basement gym the gym in your basement sauna, or like the infrared, like true Finnish style, which is big in the Nordics, is all kind of wood fire based, right? So that's what we have. We got a trailer that is, it's an old like landscaping trailer that got converted into a sauna. So it has a nice changing room, and then the hot room fits about 6 to 8 people. Big old stove in there. You pour the water over the rocks, creates the steam.
Yeah. There's
a window that looks out. So we're going to get it, parked in some nice, locations overlooking hopefully the water down here, closer to Connecticut or on the shoreline. And then, in the warmer months, we'll have a cold plunge that you could jump into. And maybe in the colder months, when we're parked near the sea, you could just hop out of the sauna, jump into the sea, and then that's the beauty of like the contrast therapy, right? Because it's you're going from hot to cold and try to repeat that cycle. So yeah, I mean, I got into this when I was over in Ireland, and tried to find something like it once I moved back, and really there wasn't much. But over the last couple of years, things have definitely started to kind of emerge here on the East Coast for sauna culture, and I think it's gonna probably blow up. There's 3 people I know just in my area who are, doing something similar. So they'll, you always want the competition, but, I think for Meg and I, it'll be pretty cool to, build something together and, just a small weekend thing,
Yeah.
to start off and see where it goes for us.
Yeah, this is exciting, and you probably experienced the benefits of it playing in your playing days, right?
Mm.
Too, being able to recover, and now we know all the benefits of both those extremes. So
Yeah.
we're going to be following your progress. So everyone, give Mike and Meg's new business a shout out. Give them a follow, and we'll be following your progress here as well. So
Thank you, sir.
best of
Thank you.
luck with
Thank you.
that.
Yeah, yeah.
So
We'll have to get you down. Now's a great reason to make the trip down to Connecticut
absolutely,
and get you
yeah,
guys in the sauna with it. Because, like you mentioned the health benefits, but it's also the social element, which I think,
yep,
we're really trying to, encourage here, because it's, everybody's looking for something else to do, especially like the Gen Z, population now, with the younger folks really turning away from drinking. The culture is less, of that. Let's go to the club, let's go to the bar, and to have an alternative to that, I think could be pretty cool. And when you're in a hot room sweating at 170 degrees, the conversation flows sometimes,
absolutely.
with strangers. So
That's
yeah,
great.
yeah.
All right.
So what about you? You've been
No,
keeping busy.
I've been busy writing and been doing a couple of side projects related to growing my work that I'm doing with my certified aging in place certification, and in shows to follow. I can share some more details on that, but I've also been in part of that process of digging into sort of the 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 wearables and the mobility and adding those features into the way I help and work with patients. I came across a study that I want to just give a quick shout out. And I want to give credit to where it's due. I actually came across this study from a guest on our show, Ralph Preston from Stroke Buddies, who does a lot of work, good work. He had the primary investigator, Dr. Swapna Balarishnan, I hope I said that right. She's with University of Vermont, and she's with their Maine lab. Now, Maine in Vermont, the acronym for Maine is Mobility and Investigative and Neuroimaging Lab. So I enrolled in this in the process of onboarding this study, and they're still looking for more participants. So I'm happy to share for anyone that's looking to perhaps get involved. First of all, it's 100% remote. The time commitment is 2.5 weeks, and they're looking at the study is using wearable devices, and it's looking at using the Apple Watch and comparing it to a GPS and another wearable patch. So for 2.5 weeks, you'll be committing to wearing multiple devices to share your mobility data, which I'm kind of committed to my watch. It was a big part and still a big part of the analytics I use to kind of keep up with my recovery and workouts. So if you're eligible, if you had a stroke with at least 6 months or longer, you can walk with or without an assist device. You live anywhere in the U.S. And I'm going to put the links I'll share in the show notes to this episode. And, in a 15-minute discovery call, you can see if you qualify and get more details from the team there at UVM. But,
Cool.
and that's sort of part one. And part two is I've been working with a former guest, Rory Perlero, who's also a SIA, so Stroke and Young Adult consortium contributor as well with our group there. And he and I are doing a follow-up episode that we're going to be recording and making available maybe on audio, but he's been doing a really deeper dive investigation into, he was one that we really focused on because he hacked his own recovery, and he was, as an engineer, was definitely into analytics, and he's taken it a step further in couple of years out, and we're going to be spotlighting, doing like an after the pod revisit to how he's actually doing more work with wearables, this time looking at using a continuous glucose monitor paired with the Stello app and the Aura Ring to give him deeper insights into controlling his blood sugar. And I'll leave it at that because when he shares his deck, it was fascinating. I said, Lord, we got to get this on and share it with our community. So
Yeah.
hopefully we'll put that across to the side group here on the podcast, also on the No Stroke Substack. So more to come on that soon, Mike.
Yeah, that's going to be fascinating to look at, and there's obviously in this the conversation we just recorded, not the episodes that we're going to be chatting through here shortly. But it's like there's these devices, there are the devices out there, that really could power so much insight into your health journey, and obviously being able to like interpret that data and take the right actions. That's where it gets difficult, right?
Yeah.
But yeah, it's just fascinating, some of the insights that are able to be uncovered by like a little ring on your finger, and or the
Yeah.
Apple Watch, right? There's so much data there to be had. But it's just, yeah, taking the action on it, I guess, is always the
Yeah.
difficult part. But
And
yeah.
we'll talk a little bit leading into, maybe you can just kind of do a quick intro to our guest today, because we do talk about that with our guest about reporting on outcomes and
True. Yep.
having those insights. So it's a nice kind of transition too to talking about, we have our guest for for the second time, but a third sort of interview in a Vivistim series with you want to jump in, and you have that in front of you, or
Sure.
um,
Yeah. Yeah. So we're bringing back on Dr. Teresa Jacobson Kimberley. She's the director of the Brain Recovery Lab at MGH Institute of Health Professionals. We had her back on episode 72,
mhm.
which is when we introduced Vivistim, the clinical benefits, and kind of walked us through the user, or the application of it, how folks are become eligible, the surgical procedure, really outlines the whole process there that Vivistim's implementing, to get patients supported with the VNS system. But this episode, about a year out, right? So we recorded that episode 72 back in May of 2024.
Yep.
So we're releasing this June of 2025, and we're discussing a 1 year outcome study for them. So, big thing, obviously, within proving efficacy, you need to be publishing in journals and publishing outcomes. So this focused around, all right, like a year ago we were discussing the opportunity, what this surgery looks like, the therapy that's needed, and now we're going to really lock in and look at, all right, well, what's it look like for folks who've started to use this for a while, and are they sustaining the gains that they've gotten after that initial batch of therapy and the stimulation. So I think we'll don't want to tease out too much, because the data there, we'll let Dr. Kimberley kind of talk through everything. But yeah, great. We're honored to have her back on. She's a wealth of information, just so easy to chat with, and we definitely love having her on. And I think it's exciting to see what steps are being made here. And I know Connecticut has actually introduced some legislation to support the Veterans Association getting
I
access
saw
to
that. Yeah.
Vivistim. Yukon Health is doing great work to really become like one of the top state hospital systems in the country right now, really offering Vivistim to patients. So great to see that happening locally here in Connecticut, and hopefully this will only continue to kind of gain now that we're talking around some of the outcomes and improving the efficacy. That should only help kind of roll the ball into other states, and help this become more mainstream.
Yeah, this is a good one. Getting her back in, and giving this update to the long-term data that they're still tracking. And we hope everyone gives this a listen and goes back. We'll link to the two previous episodes of Vivistim, and this is kind of, we'll say it's actually part 3 of our series. So
Yeah.
enjoy this one. Hi, welcome back to the No Stroke Podcast, Dr. Kimberley. It's great to have you on again.
Thanks so much for the invite. I'm so happy to be here and chat with you again.
Of course, we had you about a little bit over a year ago in May. We had a Vivistim series that we did, and I think it was episode 72 that we did a deep dive into the research you're doing. And then we did a follow-up session with a stroke thriver who had used the Vivistim system. But for those that are joining for the first time, Could you give us a quick intro and a little bit more about your background for new listeners?
Sure. So my name is Teresa Kimberley, and I'm a professor in physical therapy at MGH Institute for Health Professions in Boston. And my area of interest in terms of research is helping stroke recovery, primarily through adjunctive intervention. So like, how can we boost the brain activity and pair it with rehabilitation? So that's been a focus of my career for a long time. And I've had the pleasure of working with the microtransponder Vivistim team for a decade now, really throughout their journey through preclinical trials to FDA approval. So just to give you a snapshot of a reminder of what Vivistim is, Vivistim is a brand name of what I refer to as paired vagal nerve stimulation. So that's what it's actually doing. There's a stimulator that is attached to your vagus nerve in the neck, which is one of your cranial nerves. And the paired part is that the pulse of stimulation at the vagus is paired with rehabilitation or repetitions of movement. So there's a stim that produces activity in the brain, and then your brain is actively trying to do tasks, and that activity that you're trying to do when you're trying to do tasks, that activity gets enhanced, that neural activity gets enhanced, and ultimately we think probably strengthens those synapses, those neural connections, ultimately leading to enhanced ability to move your arm.
Great. And, I think in our first episode, we talked a lot around, the technology, the experience for a user to be able to actually get treated with the Vivistim technology. And, we had a great episode following along with an actual user of the device as well and talked through the amazing outcomes. So definitely want to point anyone listening back to both Dr. Kimberley's first episode and the episode following for the lived experience. But I think, like any new, technology, medicine, or anything kind of coming into the healthcare space, right, evolves, trying to prove efficacy. And, these early studies are so important. So, I think today a large part of the discussion is going to be around, what are the outcomes looking like? And I know you guys recently published one of the first major studies looking at outcomes for Vivistim patients. So, can you kind of walk us through, what that study looked like? The aims of the study and just, some of the outcomes here.
Sure. So the original study that ultimately led to the FDA approval was a randomized controlled trial. It was triple blinded, meaning the patients were blinded, the assessors were blinded, the treating therapists were blinded. And people were put into two groups. They either got the real vagus nerve stimulation, or everybody was implanted with the VNS. And you either got the real stimulation or you got a sham stimulation. And then you receive 6 weeks of the paired therapy. So those primary results were what happened at day one, immediately after the therapy, and what happened 3 months later. And that was published in 2021 and ultimately showed that the people who were randomized to receive the VNS, the real VNS, had a statistically higher and a clinically meaningful higher response rate. Now, this second study that we published, we followed these people for up to or at least a year after they completed their VNS treatment. So in that first study, some people were randomized to that control group, so they didn't get the real VNS. They got 6 weeks of intense therapy, but they didn't get the stimulation with it. So in this next study, what we did is we followed what happened to them after they crossed over. So they after the 3-month washout, and then we wanted to see how do people compare 3 months after they complete the therapy. and the people with the VNS were better than the control participants who got the therapy alone. Those people got to cross over and get the whole therapy all over again. So 6 more weeks of therapy, but this time they got the real VNS. So we got to see what happened to those individuals. And then we followed everybody for a year after they completed the real VNS. So a year in clinical trial world is a really long time to follow up with these people for a whole year later. And the story, the results are actually super simple to communicate, and that is that people maintained their benefit. So the benefit that everybody gained, so the crossover people matched the VNS, the people who originally received the VNS, they got additional gains, beyond anything that they gained from the therapy alone. So that really is a powerful, example that the VNS did something beyond just the intense therapy alone, because these people already had the intense therapy alone. And then the second time through, they got the intense therapy with the VNS, and they achieved a higher level in the scores. And then we followed everybody for a year, and those gains were maintained. So it's important to take a moment to talk about what am I talking about in terms of gains? What are the outcome measures? Because I think that's really one of the greatest strengths of this study, is that we had outcome measures that crossed the World Health Organization ICF model for outcome measures. We had measures that looked at impairment, and we had measures that looked at function or activity. That's like how well you can, do certain tasks, the timed tasks. And then we had measures that asked people, what is your perception of how well you can now use your arm and go about your daily tasks? And we had questions about quality of life. So, is your quality of life affected, improved by this? And the somewhat shocking thing for the results of this trial is that nearly every single measure that we did, including all of these patient-rated measures, were significantly better in the group after they received the VNS. So people improved after they received the VNS in both how they think they did, as well as the more objective measures of how well they can perform certain tasks. Yeah.
I appreciate you clarifying that on specifically the outcomes, because I was going to ask you the difference between what, like using the Fugl-Meyer score, for example, may be on the clinical side appropriate and meaningful to researchers, but the quality of life and I think looking back at measures that if someone has improved ability to use their hand and that then they can stand in the shower and bathe independently or grasp a golf club to be able to return to playing that sport they love with their friends. Those are certainly things that get me excited as a therapist when I see that, because I know that they're taking their recovery to the next level. Is there so you're looking now post a year or more out, will you continue to follow these individuals? It's already a long time, right? I know you said in research terms a year is a long time. Does that window close, or are we as new users come on with Vivistim too,
Yeah.
you're going to have a bigger and bigger database, but will you continue to track that group? Because that's a really hard design in itself, triple blind, and then the control, then have the sham procedure, then turn it on and allow those individuals. And I don't know if you can even answer that, but are they going to be followed long term?
These particular people will not be systematically followed. The ones that were originally in the study, the ones that were at my center, actually I do keep in touch with, but they're not systematically followed. The focus now is tracking real world outcomes. So people who've been implanted, at every site within the country, the sites have the ability to sign on to a registry, and patients can consent to being followed, having outcome measures, before the surgery, and then at various time points afterwards. So it's while the randomized clinical trial is of course the gold standard, and everything is followed to the T, and they're, you just know these data are really rigorous. Everybody was super well trained and all of the assessments. And I mean, it's like, right. But you also want to see what the outcomes are just out in the wild, if you will. So that's where the focus is now, is tracking, what is happening to people, just regular people who are not part of a study, who are getting implanted everywhere throughout the country. So not just at, these select sites.
And I know in our first discussion, we talked around the ability for this device, right? Like you could do therapy in your own time, right? Like you have the ability to do this in the intensive, period right after the implant, but, it's encouraged that folks do this really whenever they have the time, right? Because it is quite simple. They get kind of rubbing magnet kind of across the implant, then you have that stimulation. So what did the design look like, for these people in this study? Did they have that kind of one-on-one and like not therapy consistently, but were they doing it on their own, or what that look like?
It's a really important point. I sort of glossed over, so thanks for mentioning that. So the 6 weeks of therapy that happened with the pairing is somewhat precisely paired, in that the therapist, you're in clinic and you're going in, say, 3 times a week for over an hour of therapy. It's on average, it was like 75 minutes. So it's a good, you're there for a good hour and a half, which is a long time, and you're getting a ton of therapy that's directed by that therapist, and they're directing these repetitions, and they're challenging, and they are triggering the pulse of stimulation with every repetition of movement that you are making, that the patient is making. So that's the pairing part. We can call it like the precise pairing part. Then the patient also, so the therapist has the ability to activate the stimulator, but the patient does too. And this is what you're referring to. They have a little magnet, and they can swipe it over their device, and the device will just stimulate now every 10 seconds for half an hour while they're doing their active motion. So, and it doesn't have to be like the directed therapy that your therapist gives you these tasks that you should work on. It could just be any kind of task. So, I'm going to empty the dishwasher. That involves a lot of grasp. I'm going to use my impaired hand. I'm going to swipe it. I'm going to use my impaired hand, and I'm going to, really make myself practice grasp and release and reach. And that becomes this enhanced therapy session. But really, you're just emptying the dishwasher, and you swiped the magnet ahead of it. So that is part of, in the rehab world, we call it a home exercise program, right? Do this, swipe your magnet and do some directed therapy with your hand and arm. And they did that. The patients in the study did that throughout the whole year. So they did it, they were instructed and encouraged and supported to do that with phone calls from the therapist. They did that during the whole year. So that likely, we don't know for sure, can't say for certain, but that likely contributed to the maintenance of this effect, that they were continually swiping their magnet and using their hand. And now in the clinic, in the real world, it's even a broader definition of what those exercises should look like. And it's more like what I've just described. Like, you can do your exercises that your therapist told you to do, but you can also do anything that you're actively doing. Basically, I would tell people, you're not sitting in front of the TV, right? You're active. You're doing anything, motion wise, with your hand and arm.
And it's important that you said at the beginning that this is paired, and it's paired with movement, with exercise, intentional movement and effort. when Mike was asking that question, I was thinking, if you have, is there a point where will this shut the person down who might want to keep swiping multiple times during the day? Like, is more better, or can they only do a 30-minute
Yeah, no,
on period?
they can swipe multiple times per day. Yeah, yeah. In the trial, people swiped roughly every other day. But in the some patients now, the therapist, when they're getting implanted clinically, when they go back in to see their therapist, the therapist can look, they can scan the device and they know how many times they swiped. So there's some feedback there. Oh, you didn't swipe very often. Okay, let's talk about ways to make that more a part of your day, because it's hard to develop a new habit. You have to know where your magnet is. You have to remember to do it, and then you have to do a task, right? It's a behavior change, which we all know is, that's a really hard challenge in life, to learn how to develop a new habit. So there's a learning curve with that. But yes, no, you can swipe multiple times per day, and many people do take advantage of that.
Yeah, I was thinking, as you mentioned behavior change, I was thinking, like, not to guilt the patient into doing more, but when they come back in for their next session, they kind of know that you have the ability to see that data, right? You can
Yeah.
see you can see how compliant essentially they've been. So, um, so if we look at, so we talked a little bit about those differences and how the patients use them in clinic versus home. What is the implications? Like, what do you feel like this is saying about driving neuroplasticity, and like the mechanism of VNS is? I loved in the first discussion we had way back a year ago when you talked about, um, when when I'm teaching patients why they should invest time or effort. I love the explanation you gave about sort of exciting neurotransmitters, to, like, you got deep into the brain and talked about how that, when we talk about neuroplasticity as this golden, quest that we're after to try to make brain change, we talk about what exactly that means. And I love the ability that you were able to break it down to you sort of exciting the neurons, but you're giving that boost. So when you do
Mm.
pair it with exercise, they're more, I don't know if I'm using the right term, but they're more receptive to change, and they just kind of boost the effect. Um, is that kind of still the thought on what VNS's mechanism of action is for
Yeah.
making change happen in the brain?
Yeah, the great thing about VNS, there are other kinds of neuromodulators, right? I do research with these. You can do something called transcranial magnetic stimulation, for example. So with that, you place a coil over a single spot. And there's some debate about which side, how much you should turn it up, all these things. But it's affecting one spot. So one of the really appealing things about VNS, vagal nerve stimulation, is that I'm stimulating this nerve in my neck, which connects to some nuclei in my brainstem, and it facilitates the neurotransmitters to be released globally. It's not just doing my stroke hemisphere, just doing my non-stroke hemisphere. It's the whole brain. So that's where the pairing with the practice, with the therapy, becomes so important, because so now these neurotransmitters, think of them as just excess. Now they're all floating around in the little synaptic cleft, where the neuron synapses like talk to each other. They're floating around in there, and they're available. So here we are. There's a bunch of currency available. Who's going to grab it? Well, the ones that are going to grab it are whatever you're practicing. So if you're practicing with your arm and your hand or your shoulder, those are the ones that are going to take up that neurotransmitter and make that synapse, so that connection, make that stronger, more robust. That's the theory of what's going on. Now, we haven't studied this explicitly in humans yet. Those studies will will hopefully be coming soon. But it's been studied pretty extensively in rat models where you can, really get in and look at what is happening in their brain. So that's my guess of what's happening here, is that now we've made that practice has made that connection much more robust. So now, as we think about this study where people were a year out, and some people kept getting better. Why do they keep getting better? Because they're continuing to use these these pathways that they strengthened. They're continuing to use them, and if you continue to use something, it gets better and better and better and easier and stronger. And so it's there's theoretically like limitless gains. They're not dramatic, right? They're not an overnight, whoa, now suddenly I can do something. You still have to put the work in, and it just gives it that little extra bit to be able to form those connections better.
Yeah, so that behavior change element's probably the hardest part of all this, right? Like, so yeah, like, is that kind of where you see, right? It's like we have the science, we know that the possibilities here, the surgeries there, like everything's right there. It's just like it's kind of the, I wouldn't say missing key, but like where do you see the most important like focus for like Vivistim microtransponder, like to really try to keep driving these outcomes? Is it around that
Yeah, I
engagement?
mean, indeed, you need the person to be engaged, which is to
Yeah.
say, not everyone is an ideal candidate for this surgery.
Right.
If people don't, they need to know what the expectation is going in, because there's no sense having the surgery if you're not going to put in the effort. So at the beginning info gathering stage, people need to be really aware of what is expected, and that's why an appointment with a typically an occupational therapist who's been trained with Vivistim is a really good thing to have a conversation with somebody, because they can help understand, like, are you at a stage right now where this is a good choice for you? Because we're talking intense therapy, multiple times per week, for 90 minutes. Are you up for that? Do you need to get your just general conditioning better? Maybe you need to just even start walking, being used to having exercise before you're a good candidate for this. But so there's always that, it's not the right choice for everyone. So there's always that piece. They have to really understand what's going to be required of them going into it. But it also can be a motivator, right? Well, I'm diving in, and I'm going to give it my all for this period of time. And, so I think it can also be a motivator in that way.
Yeah, I think, like I do some work with a local nonprofit here in Connecticut, Stroke OT, and they've done some task-based therapy sessions for folks who have come out of using, or gone through the Vivistim treatment, or kind of getting ready for that, right? And I think it is the mindset. David and I, we always talk about, wanting to train, you need to kind of tap into that athlete mindset, to really train like the athlete. And, we always talk about, repetition. And it's, I think as we have this conversation and folks understand more and more about, the possibilities here with Vivistim, right? It's, to your point, like you need to be ready for that. And it's okay if, you might not be, but it's taking those small steps and preparing yourself. And, if you're not walking, like you're saying, starting small, what can you do to kind of set yourself up? Because ultimately, yeah, there's not a magic pill out there. As close as this might be, right? You're going to need to be putting the work in.
Yeah.
So I think when we talk about, where Vivistim is today and some of the outcomes, like what barriers do you see in terms of, full adoption or getting this out to a, I guess like the next stage of development here?
Yeah. I mean, so my role is, I have been a researcher of Vivistim, and I am currently also involved with Mass General Hospital and Spalding Rehab here in Boston, implementing this clinically. And so I see the barriers that are happening, within our local site. And I guess where I come from in terms of answering this question is just as a rehabilitation provider and researcher and also observer of like how this new technology is being implemented. What I really see as the major barrier is that stroke just lacks a quarterback, for lack of a better term. If you have MS, you see an MS specialist, probably every 6 months or certainly every year. If you have Parkinson's disease, you see a movement disorder specialist. You have people who specialize in movement disorders, and you see them, once a year. You go in and you adjust your meds, and if you have epilepsy, it's like all of these other major neurologic diseases have somebody who is continuing to provide your care. And people with stroke do not have that. The vast majority don't have this. So, their care is now being done by their primary care provider, probably, who is not a specialist in stroke. They don't know about the newest advances or treatment options, So I think that is problematic. I think that Vivistim is really the first new approved device in this space, this chronic stroke recovery. There's lots of things that when there's new things that happen acutely, like when thrombectomy became a viable treatment option. The patient with stroke is there in the hospital, and all of those stroke specialists are right there. But once you leave the hospital, that access to somebody who really knows about what's going on with stroke is very limited. So that's a problem because people don't know about it, and they don't know how to get people, meaning the patients, don't know kind of what the pathway is, but the health system too. There's not a clear pathway between occupational therapy and neurosurgery, is PM&R or physiatry involved or neurology involved? Like, there's not a system right now to care for stroke patients that this can just plug into, which is a problem apart from Vivistim. It's just a problem for stroke care. That whether it's your foot drop's getting worse, and there's a new orthotic that you should consider. You might not be aware of that. So I don't have a great solution for that problem, but as a patient, I would find somebody who knows a lot about stroke recovery, and maybe like your physical or your occupational therapist actually might be that person, and say, which doctors do you work a lot with who care for people, in the chronic stage of stroke? Who would you recommend I go to? That might be a good way to find the people, because there are people in most cities. There are people who care about people with chronic stroke, that are living with survivors that are living with stroke. There are doctors who care about that and stay up to date on that kind of stuff. So, but it just takes a little bit more effort on the patient's part, unfortunately, to find that person.
Yeah, I'm so glad you revisited that point, because, it shouldn't depend on your zip code where the type of follow-up care you get. And also, I think you mentioned the first time we met that why aren't we following sort of that dental care model where at least we have 2 touch points during the year, maybe like I mentioned before, that, my patients with Parkinson's often have, my patients with MS multiple times per year. If it's not the physiatrist, it's the neurologist. And I think that with that drop off, we as stroke survivors don't have that ability to learn about the new technologies. And the way you explained neurorecovery and talking about what this does, someone might just have been told, you're 10 years out now, like it's too late, like whatever you have, you have. And that's not the case. We know that. But how, I think also part of this, and maybe it goes to how as you expand and Vivistim expands to other clinical centers, how important do you feel like are your students that are doing their interns and their affiliations at, like, for example, an MGH or one of the Boston Spalding, are they, because I think that oftentimes is what can excite someone. They come and they see that patient they've worked with have these positive outcomes, and maybe it's after a year or maybe it's after 10 years. So I think like that's like going to be the missing link in the importance of getting these tech tools into like our future therapists too, that can get their hands on and actually work with patients early on, so they get those quality of life metrics too, that when they come back to clinic, they're saying like, I washed my car for the last time between sessions, those type of things. So do your students have that opportunity, or is it still early on?
Yeah, I couldn't agree with you more. Like, we have to instill this stuff into students, and people, at the beginning of their career, because we do, as therapists, well, it's not just therapists, it's sort of all healthcare providers. You develop your pattern. This is how I treat patients with stroke. And you tend to keep it. There's been studies about how well do we do behavior change. You go to a course over the weekend, you get really excited about something, and then Monday you go back and you do exactly as you did on Friday. Because change is hard. And also therapists have so many pressures on them. They've got this patient, every half an hour, and they've got to do their billing, and it's really hard, really, really hard. So the more we can allow students to hear about this, I'll tell you, every one of my students hears about this and sees videos. If they don't actually get to see a patient, they see videos. But the students who have been able to see this in action do get, they're, wow, that is a big change. And it is the things like you're mentioning, like this just the story really sticks with you, about I was able to shower standing up, and I held on to the railing, like that kind of stuff. You see the light in their eyes for the thing that they can do, and that sticks with you, definitely.
Yeah, having being able to get the next generation of talent coming, because this is only going to continue, right? Hopefully to evolve. And to that point, like, can you speak to any of the further like upcoming research that you see on the horizon with the Vivistim or just VNS in general?
Yeah, it's really an exciting time, because there's so much we don't know, and the kinds of research that I'm hoping to be able to facilitate, and some that we are actually doing now, is to try to understand a little bit more the mechanism of why this works. Because if we can understand that a little bit better in humans, we can hopefully figure out a biomarker, if you will, for who's going to be a good responder to this, so that you can know this is this would be a good choice for your patient or you. Also, that it could potentially help us better individualize the settings of the stimulation. Because right now everybody gets the same one size fits all stimulation, and it's, effective on average. We've seen some really great results, but not everybody responds, right? So is there a way to understand some physiologic marker that we can measure, that if we change this setting, this is a better setting for you? So that research is hopefully going to be getting underway soon. Another one that many of your listeners may really resonate with is walking. And number one question I always get, especially because I'm a PT, is what about walking? What about gait? So we've published one case report on this, but we're currently writing up a study on another just clinical implementation of walking with the magnet swipe. So this is a study that we did with a group at Advent Health in Orlando, where they, after patients were implanted, they finished their regular occupational therapy, they finished their regular treatment. And then, if appropriate, they then started physical therapy. So they got intense, high intensity gait training, sort of best practice PT with a magnet swipe. So they did the magnet swipe and then did PT. And we're writing up the results of that. We have a handful of patients that have followed through with that, and we had some really impressive results where people got a big boost in their gait. It's not a controlled trial, right? There was no control group that got the training without the magnet swipe, but these people were in the chronic stage of stroke where gait tends to be pretty flat, pretty stable. So it's not a definitive proof that the VNS with the gait training gave it an extra boost, but we think it's pretty robust evidence that we should do a trial to really better understand this. And we're doing some work with microtransponder to try to optimize the system so that it would work better with people when they're doing gait training. So I'm really excited about that work as well.
Well, thank you. I think that we always like to, have you gave us a great magic wand answer last time, so I'm not going to put you on the spot again, but it's still one of my favorites. So that maybe that little cliffhanger will have folks going back to listen to episode 72 and the follow-up episode with Tim Blinton, who was the individual that really Mike and I had a great opportunity to meet, and you'll hear his excitement for the therapy he continues to do with Vivistim. But if there's any last words or anything, like we're certainly going to put the Vivistim transponder, microtransponder information in the show notes. If anyone has any questions for you individually, is there a way they can reach out to you or your lab?
Sure. Yeah, I'm happy to take questions. You can give them post my email address as well. Happy to do that. And I think for the general information, the Vivistim website does a nice job. I think it's designed as an intro, it's got a section for healthcare providers as well as for patients. Okay. Is a good place to start. And then really just finding who in your area is doing this and having a conversation, make an appointment and go in and particularly with the occupational therapists who are delivering this therapy, they're going to be a great resource for you to really understand if you're a good candidate for this.
Perfect. And since this message that we also want to stress the importance of exercise in closing, I'll ask, I know you're a CrossFitter and a trail runner, and it's about 90 degrees here on the East Coast, still at 5:30, 6 o'clock. Did you get your workout in early?
I did. It was 6:30 though. It was a.m.
All
yeah,
right.
I'm not planned that ahead of time. Did not going out in this. That's for sure.
Perfect.
Smart. Perfect. All right. Well, thank you, Dr. Kimberley. It was a pleasure as always, and hope to have you back on again soon.
Wonderful. This is really fun. Thanks for the work you guys do. Really appreciate your efforts, and what a great service for patients and providers too. So.
Thank you for saying that. Appreciate it.
Thanks so much, guys. All right. Have a good one. Stay cool.
Yes, we'll try.
Bye.
Bye.